Dr. Souvik sir, are you there?
Yeah, I'm here.
Okay. So I can hear you now. I heard your voice. So let's hope. So,
Okay,
namaskar
let's hope for the
and
best.
hello everybody. Good evening, wherever you are. Welcome to today's session. And today we are going to be doing a journal club. And we have a very interesting study today. It's called the SMART study. And it's one of the largest studies. In fact, it's the largest study ever conducted to determine the dosing of meropenem and piperacillin tazobactam in CRT patients. Till now, we do not know what is the exact dosing for meropenem and piperacillin tazobactam in CRT patients. So this study was published in Intensive Care Medicine Journal in just this month, September. And the presentation will be from All India Institute of Medical Sciences, New Delhi, and we are indeed fortunate for that. And we thank Dr. Souvik Mitra and Dr. Bikash sir for organizing these journal clubs from Aims. And it will be presented by Dr. Vasundhra Rakhi. She's a DM Fellow in All India Institute of Medical Sciences, Department of Critical Care Anesthesia, New Delhi. And she has been guided by Dr. Souvik Mitra, who's additional professor, Department of Critical Care Anesthesia, Aiims, New Delhi. And you all know Dr. Jeetendra Sharma sir. Sir has been very kindly presiding over all these journal clubs and guiding us. So sir is, just to mention again, he is the head and chief at Aiims Hospital of Critical Care, Gurgaon. So with that, I think we shall start now. Over to you, Dr. Vasundhra.
Thank you, sir. Good evening, everyone. Today we'll be discussing the study which was published on 2025 August, 13th August. The study is meropenem and piperacillin tazobactam optimized dosing in critically ill patient receiving renal replacement therapy. It's not moving, sir.
Jeetendra, the slide is not moving. Yes, it is moving.
It's starting now. It's starting now. Okay. So, in critically ill patients with acute kidney injury, they frequently require renal replacement therapy. And dosing antibiotics like meropenem, piperacillin is complicated due to the altered pharmacokinetics. An inadequate dosing risk therapeutic failure or toxicity is seen in up to 25 to 40% of the cases, and in which it does not reach to the target antibiotic concentration. Now, meropenem and piperacillin are amongst the most prescribed antibiotics. That's why meropenem and piperacillin are chosen in the study. And beta-lactam's efficacy is related to the percentage of time which the drug is above the minimum inhibitory concentration. Unbound concentration is maintained above the MIC for the infected bacteria. And in severe infection, we want the 100% of the time it should be maintained above the minimum inhibitory concentration. And some preclinical data also suggests that maintaining higher drug level can lead to prevent resistance, but it can improve the efficacy, but it can lead to increase in toxicity. Now we have this Blink trial, which was published recently. So it included critically ill patients more than 18 years with sepsis admitted to ICU. And in this, they did for the intervention, they choose beta-lactam continuous infusion for 24 hours. In this study, also piperacillin and tazobactam were chosen. And for control, they did an intermittent infusion with 30-minute infusion at usual dosing interval. So the outcome of this study was there was no significant difference in 90-day mortality, continuous versus intermittent. It was not statistically significant, but clinical cure and some secondary outcome favored the continuous infusion, but without any statistical significance. Now, in our study, our objectives are to develop a generalizable dosing recommendation for meropenem and piperacillin tazobactam during different RRT modalities, and to understand the pharmacokinetic variability in critically ill patients on RRT, and to propose a dosing normogram incorporating the patient's factors and RRT settings. So the study design was, it was an international study, prospective and observational pharmacokinetic study. Almost 300 patients from 22 ICUs, 12 countries, adult ICU patients with severe AKI needing RRT were included. And the modalities for RRT were CVVHT and hemofiltration, and SLED were taken into consideration. For inclusion criteria, expected RRT of more than equal to 4 days, receiving study drugs, and exclusion were short and anticipated RRT or any lack of consent were all excluded from the study. In this, they have collected almost 8,322 samples from 234 patients for model development, and external validation ke liye they have taken some 66 additional patients from different centers and confirmed the model's generalizability. Now, for method sampling and data collection, the antibiotic dosing in RT settings at treating team's discretion and rich sampling was done. So, post-filter plasma, effluent fluid, and covering the initial and the maintenance phase. So, they did a quite rich sampling. Measured total and unbound drug concentration using validated ultra-high liquid chromatography and tandem mass spectrometry method. Then they collected demographic data, detailed pharmacokinetics and pharmacodynamics, and clinical variables and RRT specifics. Pharmacokinetic sampling was done on one or two occasions over a dosing interval, day 1 or 2 or 3 to 6 after the antibiotic commencement, accounting for initial, and the later was taken as a maintenance phase of the therapy. 3 ml of the blood was taken. So you can see from here that the sampling was done quite meticulously, and it was a rich sampling. So pre and post filter RT ports were done, and for effluent sampling, they did at 180, 240, 360 time. If the dosing was beyond that, beyond 24 hours, they have done T480 also. So this is just a slide to show that how meticulously they have done the sampling. Now we'll see how the demographical and clinical characteristic of the patient. So in this, the main things to notice is that most of the patients were of the adult male population, around 60 to 65 age group, and the weight was around 85 to 80 in average. And most of the infection that they have covered our respiratory and abdominal infections. And in this, most of the patients were on vasopressors, and they were mechanically ventilated. This was the significant part which we will discuss in this. And then the modality was hemodiafiltration. And the mortality was mostly of 44% in this study. So in general, what they did was they took 300 patients from different ICUs. They determined their RRT modalities. They collected data, and quite rich sampling was done from post filters and influent samples. And they then developed a model based on a software. They developed a pharmacokinetic model, and then they did a Monte Carlo simulation, which we'll discuss later. And dosing optimization was done. And then with this, they have developed a normogram, which we'll discuss in the study. So for pharmacokinetics and statistical analysis, they did a monolix modeling software, nonlinear mix effect, for which the population pharmacokinetic model was developed for each drug, integrating the multi-compartment measurements. And for the evaluation of this model, they did a goodness of fit plots, observed versus predicted concentration. So what is this goodness of fit plot is? Basically, how close the model prediction are to the observed data. It tells us that. And then they did a prediction corrected visual predictive checks for model accuracy over the time. So this compares the predicted concentration ranges to the actual concentration over the time. And then they did bootstrapping. Bootstrapping, the word itself means repeated sampling. So the repeated sampling of the patient estimated the uncertainty in the model parameters. And finally, they did performance metrics with mean predicted error and mean absolute predicted error. So mean predicted error is how much the prediction deviates from the actual values on average. And acceptable was taken as less than 30, but optimal was less than 20%. And similarly, mean absolute prediction error is average absolute difference between the predicted and the observed concentration. So it is comparatively a better marker. So next they did a Monte Carlo simulation. So they ran thousands of virtual patient simulations, and then out of that they predicted the efficacy by percentage of patients which have achieved the target drug concentration, and then predicted the toxicity risk based on the concentration thresholds, and then identified optimal dosing regimens with more than equal to 90% target attainment probability. For model validation, finally, then after this, they have come to the results as this will discuss internal model performance for the MP, which we have discussed for meropenem was 5.2%, which we can see the optimal was less than 20%, which is much less than that. And mean average prediction error was 25 to 8%. And then MPE for piperacillin was 16.9%, and MEPE for piperacillin was 29%. Predictive pharmacokinetic model performance were similar for development and the validation sets, which we'll see later, and high external validity across the modalities, the patient types and centers were seen. Now, after this, they developed a final model for meropenem population. Pharmacokinetics parameters were estimated. And along with that, they have compared with the bootstrap results also. So in this table, you can see BC represents the central compartment, and this VP means peripheral compartment, and then Q is the intercompartmental clearance, and intensity refers to intensity is the effluent flow rate and the dialysate and the replacement fluids. So that represents intensity, and then urine output. So basically, when we they have given the results in RSE, that means relative standard error. So relative standard error indicates the precision, and shrinkage percentage represents the reliability of the value. So this table is showing the average value for each parameters as estimated from the population data alongside the statistical measures. So this median bootstrap estimates, this is showing in with 95% confidence interval. This is showing that the reports, it is basically showing the robustness of our values, indicating that the median value from the resampling at 95% confidence. And so how are we going to come to the, like, how are we going to analyze this? Basically, if high RSE is there, that means it is less precise. And shrinkage percentage, if it is less, that if it is very high, then it suggests that there is a less confidence in the distinguishing it from the real variability. So from this, they have derived this is the table for meropenem. This is the table for piperacillin, saying you can see. And after this, basically, they came to three critical factors that determine the antibiotic dosing requirement in RRT patients. So that was RRT intensity. Intensity in that includes dialysate flow, then replacement fluid flow rates, urine output more than 500 ml threshold for meropenem, and more than 100 per 24 hours for piperacillin tazobactam, and RRT duration. So these were the critical factors which were mainly affecting the values. So after this model and model validity, they finally made the nomogram, in which the meropenem dosing normogram for standard steady state concentration target was more than 2 milligram, and for higher targets were more than 4 to 8 milligrams. And the toxicity threshold was taken as 45 milligrams. So this is the final table which is very important to us. So for continuous RRT, if a patient is on continuous RRT, and we have to see next what is the intensity we are prescribing for the patient, and then next comes how is the urine output of the patient. So urine output may if he is oliguric or if the urine output is less than 500 ml 24 hours, that we have to determine. Now standard target के लिए if the patient you have given continuous RRT at 1.5 liters per hour, then the prescribed dose for meropenem is 1 gram to 1.5 gram per day continuous infusion. And for this higher target, it is 1.5 to 2 gram per day continuous infusion. And if the urine output is more than 500 ml per 24 hours, then you will go for 1 gram to 1.5 gram per day continuous infusion and 3 gram per day for higher targets. So this is the dosing for continuous RRT, and we can similarly see a short sled that is less than 6 hours, intermediate sled less than 8 hours, and for long sled also we can see the dosing here. So in general, if for all type of modalities, they have concluded that 1 gram of loading dose over 30 minutes short infusion, and immediately after that initiate the continuous infusion at the recommended whatever it is recommended in this according to this nomogram. Now, continuous RRT के लिए for piperacillin tazobactam, they have taken the unbound average concentration target of more than 16 milligram, and for higher target, they have taken more than 32 to 64 milligrams, considering a toxicity threshold of 160 milligrams in this. So now what do you have to see? We have to see which modality we are prescribing, again the intensity, and if the patient is anuric or the urine output is less than 100 ml per 24 hours. So if you are prescribing CRRT to a patient with an intensity of 1.5 liters, then we'll 1.5 liters per hour, then we'll give a piperacillin tazobactam 3 gram to 0.725 grams to 8 grams to 1 gram per day continuous infusion. Suppose if we have to start the treatment, then we'll give a 4 gram and 0.5 gram loading dose of piperacillin tazobactam over 30 minutes, short infusion, and immediately after that we'll initiate the continuous infusion at the recommended daily dose. Similarly, for short sled and intermediate sled, we can follow the nomogram. And after this, they check the target attainment also, and probability of achieving the pharmacokinetics in the standard targets, that is infection with Enterobacteriaceae. They maintained a MIC more than 100%, time above the MIC more than 100%, and most of the regimens more than 90% were following the nomograms. For higher target, they needed some high continuous infusion. This higher target was for the difficult to treat bacteria, Pseudomonas aeruginosa, empirically treatment for some resistant bugs. And then for trough below breakpoint, meropenem, it was 1.3%, and piperacillin was 4%. Above toxicity threshold. And for above toxicity threshold also they checked, it was just 1.5% with meropenem, and piperacillin ke liye it was 11%, which is very less. So finally, now after all this taking this study into consideration, how we will deal with our patients. When we have a critical ill patient with AKI receiving RRT, the patient is not under treatment. The treatment is not yet started with meropenem or piperacillin. So you'll administer initial full dose over a short 30 minutes, then check the urine output and RRT intensity and duration according to the nomogram. Then immediately after administering the loading dose, initiate a continuous infusion with the recommended daily dose from the nomogram. Already the patient is on treatment with meropenem or piperacillin. So then we will check the urine output and RRT intensity and initiate a continuous infusion with the recommended daily dose from the nomogram. And then we'll titrate this dosing using the nomogram based on the changes in urine output and RRT intensity and duration. So this is just a gist of what all we have read till now. So finally, the study concluded that the dosing must be individualized to the RIT intensity and urine output. Extended and continuous infusion regimens improve the outcomes and it lowers the toxicity. The dosing strategy supports more effective ICU antimicrobial stewardship. What were the strengths of this study? It was the largest multinational prospective pharmacokinetic study in this domain. Diverse patient mix and RRT types increase the generalizability, robust methodology, rich sampling, and advanced pharmacokinetic modeling was there, and strong statistical validation, which we have discussed. And practical outputs, mean they have given us this nomograms and algorithms for the frontline intensivist. Now, what are the limitations of the study? So, data mainly for continuous and SLED RRT. Caution if applying to other modalities like intermittent hemodialysis or ECMO. Limited data for obese and cachectic subgroups. The average body weight of the patient which they have taken into consideration was 80-85, and most of the patients that we deal with in Indian scenarios are different. And then they have taken the plasma pharmacokinetics, not the infection site pharmacokinetics. So coming to critical appraisal, was the study question relevant and clearly defined? Yes. And the objective and hypothesis were stated clearly. The study design was evident in the abstract, and the study performed according to the protocol with no conflict of interest. The eligibility criteria and participant selection were mentioned. Then exposure and confounders and outcomes were clearly defined. And the bias was addressed by multinational approach and sample size was justified. And it was the pharmacokinetic modeling was robust and adjustment for missing data was done. So they have done like statistical methods and missing data were well handled. The participant flow for eligibility to analysis report was done, and baseline data and key confounders were presented. Main outcome measures and confidence interval were reported with the clearance and volume distribution estimates. And the generalizability of the discussed findings were discussed. And the study limitations and potential sources were also mentioned in the study. Limitations due to heterogeneity and RRT strategies were noted, and funding and sponsors were explained. And the results were applicable in real world, as we have discussed. The local adaptation was advised. Thank you.
Please stop your share screen.
Yes, sir. Can you stop sharing? Okay, yes, done.
Thank you, Vasundhra. You have done a great job because the study is of little different design because the pharmacokinetic studies are less discussed, at least in general journal jobs. So it was a different design, and you have portrayed a simplified approach, for the perspective of intensive care physicians like us who want to actually optimize our dosing schedule of BLBLIs and meropenem, and also minimizes the toxicity as much as possible. So this will be from day-to-day practice point of view. It will be great help to all the intensive care physicians practicing in India. But obviously, at the last of that, actually said that local adaptation is important. In the subsequent discussion, we'll look into the study in even greater detail into this.
Thank you. You have presented the paper in a very. Am I audible?
Yes, sir.
Yes, sir, you are audible.
So, 2, 3 important points here for the clinician. First is how do you take this study? Do you think now the study is the completely end of the further investigation or studies to be done related to pharmacokinetics? Has it given all the answers related to the dosing of these two particular antibiotics, the critical ill?
Sir, as I have mentioned in the limitation of the study also, that mostly this study has taken into consideration the CRRT. And most of the patients that we come through undergo SLED or intermittent hemodialysis. The percentage of SLED also that has taken into consideration were less compared to the CRRT group. So for them, we need another more like different study to give us some more data regarding that. And sir, also the weight of the patient, which I discussed, because Indian general population weight is comparatively less compared to the weight that they have taken. So that is a limitation, and
So, good, excellent. That limitation actually explained by the author also. These are the things. But let me put in the different perspective. For the clinician, so technically, the primary endpoint of this study was to attain the MIC level up to a certain targets. Obviously, it was different from the usual and the resistant organ. But the primary endpoint was a surrogate marker of your therapy. It is the concentration of the drug, that too in the serum level.
yes,
So,
sir.
what is the two major? Uh, please take it in a correct way. Study is excellent, and it served the purpose for it actually designed for to attain the primary endpoint. But what I mean to say, the clinician still it is not the end of the world, because the two major variables exist, because we are giving this medicine antibiotic to treat the infection, and
Cure
patient
it.
should get better.
Yes, sir.
That you already touched this point. The study didn't cover the microbiological clearance, whereas the primary aim of the drug is not to attain the serum concentration. Ultimately, the treatment.
Yes,
So
sir.
it definitely the study served the purpose for it. It was designed. Eventually, at this moment, at present moment, we are studying uh, in this. We used to assess the antimicrobial efficiency based upon the serum concentration attainment according to the pharmacokinetic model. That is from the current perspective. Eventually, what we wish to have probably the concentration at the tissue level may differ. So your MIC, and then we have to, and eventually is this drug is able to clear the uh, uh, microbial clearance is there or not, and eventually the especially mortality and the relief of the skin. That's why still these type of study will keep on coming, and as we grow in the technology, so there may be a next step is to attain the concentration at the source of infection where the tissue is there. That will give you a little bit edge over there. So typically, still the study is the studying the surrogate marker of the efficacy and effectivity of the antibiotic. That is the because ultimately we measure the study. So now, whatever we information gathered from, how we can use this information to treat the patient from the next day, by, say for example by tomorrow in the ICU.
So, sir, as we'll follow this nomogram, but wait, sir, same the modality which we have to see, and the dose that we are giving, the duration for the modality which we are using, and then accordingly the which infection we are treating, that is also important. If it is difficult to treat infection, then higher thresholds will be used. If multi-drug resistance bugs are there, so we'll go for higher concentration and standard, according to the nomogram, a standard drug dosing, which we have seen in the nomogram, which will follow that. But sir, same, the weight thing has to be taken into consideration and the modality that you're using. If you're using CRRT, then it's fine. The dosing can be followed. SLED, I'm little skeptical. I'll be little skeptical while using the dosing nomogram and in intermittent hemodialysis also.
So, of course, that is a major point in this paper. Is one is modality of the and intensity of the RRT. Intensity, which means to be a typically hemofiltration, then the how much actually your hemofiltration dosing, that determine the intensity, and the for the slide is the duration. These are the specific point related to the study. Now, when it comes to the our routine practice, so the major
Continuous infusion.
change here is what a normally creatine clearance based dose adjustment is not applicable. That is the first and foremost information for the clinician is there. We can see despite your normal level, not the higher attendant, still they require 1 and 1.5 gram per day meropenem, which in usual circumstances people tend to cut it down to the 500 twice a day, maybe a 1 gram, and sometime maybe a once in a day also. So that the important thing is most of the time we are keeping the underdosing. As if now when we give the medicine based upon the creatine clearance, and especially that creatine clearance concept comes from the end stage renal disease model for the maintenance hemodialysis patient, which may not be. The things is really very much different. Somebody is having a SLED today and day after tomorrow, and another is having a today and the next day. So every day somebody is having a SLED and the other is having a every alternate day. Things is entirely different. So in this way, and the second is if we completely follow that model, 11% for piperacillin tazobactam crossing the toxicity threshold. So number is less, but again, we wish to have that should be somewhere 2 to 3% only, because the toxicity threshold even 10% is reasonably high. So the bottom line is this.
Also, that the toxicity levels data that we have are generally taken from retrospective data. So that is also like limiting factor in that.
Yeah. Obviously, when it comes to a surrogate marker, because the toxicity level is also very arbitrarily level. To whom, what toxicity? Probably somebody may be having a before the toxicity level attained, and somebody may be a more than that. Whatever happens, once we draw the line and still having 11% is reasonably good. That's all from my side. Anything else, Dr. Souvik?
Yeah, probably will be the future studies. We should conduct, especially for our patients, considering the body weight, number one. Secondly, the RRT modalities and time that we undertake in that particular ICU, which is commonly practiced in India. So, and if possible, simultaneously the effect site concentration at where the infections are. Actually, we're targeting the infections, like patients with a intra-abdominal infection. If we can sample the peritoneal fluid, or maybe the epithelial lining fluid in patients with pneumonia and VAP, or maybe some other lung infection, so that can be designed and required. And secondly, how the optimized dosing helps in curing the patient, the infection, and affecting the outcome, the hospital mortality, ICU mortality, and obviously the duration of antibiotic therapy, etc. This clinical patient-centric outcome, how they are affected by the pharmacokinetic based dosing regimen needs to be evaluated in our patients who are usually have less body weight and expected to have a different kind of RRT modalities used. So that needs to be thought by us, like clinicians who are practicing in India. That's all I can add.
Just one point I would like to add after actually going for this paper is usually clinician ignores the when urine output happens. Most of the time,
Exactly.
the
Yes.
adjustment revolves around the clearance only.
Yes,
So here the
absolutely.
important concept introduced here is the de novo clearance and the renal your RRT
Yes.
clearance. So both has to matter, and when it crosses the 500 ml per day, that is kept in the study. Probably it may be 400, 300 also, because
Yes.
the researcher kept it as a 500. That affect the serum concentration uh, significantly. And more than 500 and the 1000 maybe drastically, which is usually ignored by the
Yes.
clinician in a clinical practice. Everything revolves around the renal clearance and the creatinine. So that's very important. Hardly
Yes.
people pay attention.
Absolutely.
Uh, Renal AKI patient or whatever AKI or CKD patient, whether the urine output is there or not, because it makes a difference where the urine output is there is some clearance is there, and absolutely anuric then.
Yes.
So that's an important point actually clinician
Yes, agree.
can consider right now in that.
Yes. Particularly in patients, maybe difficult to treat infections. If we are thinking patients with non-liquidic AKI, this being CRRT, SLAD, or even IHD. So probably a higher dose may be beneficial in this group of patients where we have the conventional dosing regimen may not be accurate. The study indicates, and definitely that in our future clinical practice, so particularly in this patient, we should keep in mind. Absolutely, sir, you are absolutely. I agree with you.
Yes.
So the last message, what we get in the coming era, of course, not immediately, maybe in the next 20, 25 years, probably we'll have a model directly measuring this case in the form of the some color coding and all these things. This is arranged in the dosing according to that. Then you hardly need to really remember what is the exactly dose, and uh, that is going to happen very soon in the future. So that all the study and eventually they will be applicable, and then finally what we call as a precise medicine would be there. So you directly see what is happening in the patient, and you.
So TDM at the bedside, let's say.
TDM is one point. It will be.
At the bedside.
It's like a continuous glucose monitoring.
Continuous.
Say for
TDM at
example.
the
For example, 30, 50 years back, nobody actually imagined the continuous glucose monitoring eventually gave us. And then it's exactly the same way most of the important drugs, it will come in the continuous monitoring level, and then.
And
Of
in
course.
real life, as of now, the HPLC and mass spectroscopy is not easily available. In our institute, also, few faculty members have their own lab, particularly for biochemistry and biotechnology. So, for their own research purposes, but doing HPLC as of now with mass spectroscopy is technically demanding, and moreover, availability is the main issue, along with cost, obviously. So maybe we wish something in some point of care testing may be available in the next 15, 20 years, next decade, probably.
Not near future, but maybe,
Maybe.
these are the way which we are progressing.
And even we ask if you ask the person or faculty who has access to this HPLC and mass spectroscopy, they are so overburdened. So if you ask for even one or two patients at times, so even if they can financially, they can probably bear accessing the institute, but doing it's little difficult. But definitely the study is thought provoking. I'll say it's thought provoking. Definitely I'll look into it in future that whether at least in some patients, like you identify the patients with the urine output, we can do some at least modified TDM to optimize the drug regimen. Thank you once again, Dr. Jeetendra and Vasundhra, for excellent presentation.
Just one thing I would like to say, just I can catch some broken sounds. I think we are finished. So I would just like to, say something, a few things for the audience because I have not been able to catch most of the things. Why it was difficult to dose, and it is still difficult to dose despite this study, is because of the variability in the various factors contribute to the serum levels of antibiotics in patients with AK and CRT. And this is because of the unbound and the bound fraction. So the binding occurs to albumin. And the binding to albumin is determined by the serum albumin levels, by the pH, by the urea levels. That is very important, right? So the unbound and the bound fraction varies in different patients. And the volume of distribution changes of the drug because of altered serum albumin levels. And per se, because you're giving different volumes to different patients. So there was so much variable and pharmacogenomics. And again, extra renal clearance of these drugs. So there were so many factors involved in the serum levels of the unbound antibiotics. And that is why we were never able to get to a particular dosing regimen. And what studies were conducted were small numbers and very heterogeneous, so there was no clear dosing that we had. And again, in this particular study, they have not looked at the pH, they have not looked at the urea levels, they have looked at the albumin levels. So definitely the pH and the urea levels, because they determine the binding to the binding of the drug to the albumin, make a difference. And I don't know why they have not looked at it. And the other point is that I think most of the patients had a normal serum creatinine. Most of the patients had a normal serum creatinine, and most of the patients were on vasopressors. So again, the generalizability factor becomes a little limited. So definitely, these are some of the things I think that are missing in this particular study. And maybe Dr. Jeetendra and Dr. Souvik can comment. I'm sorry, my audio is not working very well, but this is what I wanted to say. I didn't catch any of the discussion, but I thought I'll just add a couple of things.
Yes, Dr. Tapesh, you are absolutely correct. So, the things you have mentioned, probably I think they wanted to make a simplified model, and the factors which, at least in that data set, affected strongly the pharmacokinetic modelings that they considered. So, they measured the albumin level. pH, I'm not very sure, but albumin level was measured and reported both in the derivation and the validation cohort. Might be it was less important than the other factors. So that obviously thought provoking. And secondly, often in our practice, we see patients with chronic cachexia already. They are having a poor nutritional status, so might be relevant in our practice when the patients are having albumin around 2, which is very frequent in our critical ill patient, at least in our hospital. This is definitely needs to be thought in the next decade, probably I'll say, during dosing. And pharmacogenomics, that is also, it's coming in a big way. Though it is not available, I think in most of the institutes to look into the metabolism profile of the drugs. But yes, in future we might get researches done in these areas also.
One. I think if everybody has finished, one question for Dr. Vasundhra. Dr. Vasundhra, how is toxicity of antibiotic determined? Is it is multiple of MIs of the breakpoint or what?
Hello.
Yeah, so there's one question for you. Can you hear me?
Hello.
Yeah, I can hear you. I can hear you, Dr. Tapesh.
Dr. Vasundhra, one question for you. How is the toxicity of an antibiotic determined? Is it a multiple of the breakpoint or is there some other method? We talked about toxicity in this particular study.
I think Vasundhra is not able to hear you, Dr. Tapesh. So what I have understood from the study in this particular research, they have taken a predefined cutoff value of serum level, which has been previously reported in some previous studies. So it was not more than 10 multiple of breakpoints was reported also. So that was a potential toxicity level. And they have also used a predefined cutoff, which was derived from previous literature.
Yes. So that is true about this study.
Hello, am I audible?
Yeah, you are audible. Can you hear me? All right. So I'll just say for the audience, I think they're having some interruption. So the toxicity of an antibiotic generally is determined by animal studies. It is not a multiple of the breakpoint or anything, because animal studies are somewhat easy to do, and you cannot ethically do toxicity studies in human beings, and that is how you actually get toxic levels, or predefined toxic levels. These are derived from animal studies, and when you do get toxicity in a particular patient, you can, if possible, measure the serum levels. So this is something. It's not a multiple of a breakpoint or anything like that. Okay, so Dr. Jeetendra sir, final words, anything? Yeah.
So we have discussed all the aspect of the study and the future kind of with this. Of course, the mentioned toxicity. That's what we discussed. Also, the mentioned toxicity level is purely from the references for the previous studies on, not that particular patient they observed. So 10% they reported based upon the purely cutoff value based on the previous studies, not actual toxicity.
So actually, I lost the connection in the between.
Yeah,
I can hear you.
Okay, that's okay. We have discussed that. Discussion was okay. No problem.
Sorry.
So most of the points we have discussed, I think we can close this session, Dr. Tapesh.
Thank you, sir. Thank you, Souvik sir. Thank you.
Thank
Okay,
you.
thank you.
Thank you, sir. Thank you, sir.
Okay,
Thank you.
then, thank you. Sorry for the
Thank you.
interruption. I think there was a problem with my internet, and I think Dr. Vasundhra was also having some problems in the end. I hope it was
Yes.
good for the audience. Sometimes Zoom causes problems, I think internet frequency, etc. So thank you, dear audience. Thank you very
Thank
much.
you. Thank you all.
Dr. Vasundhra. To Dr. Souvik sir, thank you for making this possible.
you.
And
Thank
Dr. Jeetendra sir, thank you for mentoring it. Thank you very much.
Thank you. Thank you.